My name is Michelle Trang, and I'm an MS2 from UTMB Galveston, and I'm joined by my co-moderator, Shreya. Shreya is a medical student from India. Is your mic working?
Yeah, I think it just got stuck. Sorry about that. Hi, everyone. I am Shreya. I'm a fourth year medical student at ESIC Medical College from India.
Just as a reminder, in respect for everyone's time, there will be a chime at the 3-minute mark and the 1-minute mark that sounds like this.
Sorry, 1 second. Here we go.
There we go. Before we open the floor to questions from the crowd. So without further ado, I will be inviting each speaker to introduce themselves, starting with Dr. Zurstrassen from Brazil.
Hello, good night. Oh, well, here in Brazil it's night. Thank you very much for the invitation. It's a great pleasure to be here, and thank you.
Next, we have Dr. Ahmed from India.
Hi everyone, I'm Dr. Sabha. I must congratulate Shreya and the team for the flawless organization of this program. It's early morning in India, and I know Shreya has been up all night, on it. So yeah, great. I'm an anomaly here. I must warn the audience. I practice primary neuroimaging and interventional neuroradiology. So unlike most of the panelists here, I don't do any body interventions, but yeah, we'll see how it goes.
All right, next we have Dr. Tan from Singapore.
Hi, everyone. Thanks to the committee for having me. And it's really nice to see the enthusiasm of all the students with us and residents as well. My name is Alfred. I'm one of the interventional radiologists from Singapore. I've spent most of my time actually in the UK for about 15 years studying for medical school before coming back to Singapore to take up a consultant job. And I've been working in Singapore General Hospital for the last 5 years. Thanks.
And finally, we have Dr. Park from South Korea.
Hello, I'm Dr. Park from the Severance Hospital in Seoul, South Korea, and I'm excited to be here and share a few of my insight to become a good interventional radiologist.
Alrighty, so let's get started with our first question. We'll answer the questions in the same order that I introduced the speakers. Our first question is, how does IR training differ in your country compared to the US integrated and independent residency models?
May I start? All right. To become an interventional radiologist in Brazil, you should, of course, read a medical degree, and later you have to do a diagnostic radiology fellowship. And then if you want to apply, you must apply for interventional radiology program. There's no much credentiated interventional institutions here in Brazil. It's more or less 20. Most of them are located here in São Paulo. 14 of them are in São Paulo, indeed. And the others all around the country. So we're still lacking a little bit of professionals performing interventional radiology, vascular interventional radiology. And even though vascular interventional radiology is, you can treat, you can do oncology, you can do to treat vascular diseases, you can do do procedures in a general hospital, for example, fibroids, prostate, bleeding. So it's a little bit hard to find a place to have all the learning necessary to become a complete vascular interventional radiologist. In most of the cases, you should do not only endovascular procedures, but but percutaneous guided procedures as well, ablation, biopsies, drainage, and so it's quite complex here in Brazil to find a place where you could be trained to perform all the procedures that I have been describing.
Yeah, thank you. And Dr. Ahmed, what does it look like in India?
Yeah, so I'll just give you a ballpark of numbers to begin with how it's structured in India. So we have what we call as the NEET PG and we call as the INI exams, and these are typically given after a year of internship. So right after this, we have around 2,500 spots for radiology. I wouldn't call it diagnostic or interventional, just radiology, the basic MD level training for the entire country to vouch for over this, after they've given the exam and you're basically allotted seats depending on, the ranking and the scores. So there's about 370 medical colleges offering about 2,500 radiology spots annually. This is in stark contrast to what we see in terms of the spots available for interventional radiology, where the amount of seats offered or the spots offered, we boil down to just about 50 in some of the most elite institutions across the country. So this essentially means that we have less than 2% of the radiology trainees, can essentially access structured and degree granting IR training. So, aside from this, we also have what we call the fellowship pathways, where, private hospitals in India also offer fellowships ranging from anywhere between 6 months to a year or 6 months to 2 years, depending on the need of the hospital and also the expertise of the mentor there. So that amounts to about 150 spots. So in totality, we offer spots for about 50 to 200 interventional radiology trainees every year, as opposed to the 2,500 radiology spots that exist in the country for primary diagnostic radiology training. Having said that, I will say this, the 2,500 spots I mentioned, now the training here is very varied. For instance, I went to an institution where I had early access to interventional radiology. And, much to the surprise, when you have early access to something as important as interventional radiology, and it's very diverse again from the diagnostic radiology, you do have the time to decide as to whether you would want to continue, whether you would want to pursue this as something for life, as opposed to making the decision much later, which happens with some of my colleagues who haven't really had exposure early on in terms of interventional radiology during their diagnostic residency program. Then again, like I said, I'm very much an anomaly here because in terms of interventional radiology, again, we've branched it out into vascular interventional radiology, which essentially it traverses the gamut of percutaneous procedures, much like what Dr. Charles mentioned, and then you have the vascular procedures as well. And then we have the neuro IR spectrum of it. So some of us, like for instance, I wanted to delve only into the neuro IR aspect of it. So I pursued a specialized training in neuroimaging and interventional neuroradiology. Again, the number of spots for this very limited. It boils down to probably 5 to 6 centers in the entire country that can provide this. And yeah, I can't help but notice I'm the only female on the panel. So we have less than 10% of our IR trainees as women taking up on these roles. So I mean, I'd be glad to have a lot more of us on the panel here and have wider representation worldwide. Yeah.
Thank you very much. Dr. Tan, what do you say about Singapore?
Yep. So we don't have a dedicated IR recruitment track in Singapore. Entry into interventional radiology as a specialist is still via the 5-year clinical radiology residency track. And during that 5-year period, you spend probably about maximum of 13 months, being able to be exposed to interventional radiology. So a lot of the training takes place after you finish residency. And in my hospital, we have a 2.5-year training program where the consultants would rotate through 6 months blocks to be exposed to different aspects of interventional radiology, both vascular as well as interventional oncology. I think where it shares similarity to the US is that a huge part of the training still entails diagnostic radiology, and also in terms of the exams as well, most of it which will be tested on will still be diagnostic radiology. I think that's where we are quite similar. Yeah. Thank you.
Yes, and finally, Dr. Park, how's it in
Yes,
Korea?
Yes, I think it's similar to what's happening in Singapore. So only pathway available is after you finish the 4 years of the clinical radiology, you get to choose your own specialty. But during those 4 years of the clinical radiology session, you get to be exposed about 6 to 8 months of the interventional radiologies. And after finishing the radiology, you spend about a year or two in the vascular interventional radiology fellowship, and the after finishing those 2 years, you have to submit for a certification from the Korean Interventional Radiology Society. And after you finish a certain number of cases for each procedures, then you get to be certified as the board certified interventional radiologist in Korea.
That's awesome, Dr. Park. I would like to ask again, what is a typical pathway for medical students or residents to enter the IR in your country? What would it look like? Dr. Charles, you can start.
So here in Brazil, there's no single institution that can provide all the knowledge, all the training for a doctor to become interventional radiology, able to do all the procedures that can be done. For example, in my institution, I work in a cancer center, and we do have a fellowship program. And unfortunately, our fellows are very well trained in oncology procedures, heart embolization, intraarterial chemotherapy, embolization of bleeding, portal thrombectomy. But in the other hand, the other hospitals that are more focused, for example, in vascular disease, the fellow are better trained doing vascular disease. It's a complicated issue that our society, Zurstrassen, are trying to solve, making some training, some exchange training between the institutions that may help the fellows to be better trained in another field, in interventional radiology. I don't know. I believe it's also an issue in other countries that there are institutions more focused in one specific field of the IR, and well, that's what we get, and that's what we've been doing. Independent of that, the fellow, after completing the whole training, should apply to an exam to the Interventional Radiology Society and Endovascular Surgery, Zurstrassen, to get his approval and to become a specialist able to work in any hospitals of Brazil, performing IR procedures, not only endovascular procedure, not only but also percutaneous procedures. So, as long the fellow is approved in this test, he's allowed to perform endovascular and percutaneous intervention as well.
Awesome. Thank you, Dr. Charles. I think Dr. Sabha, can we have your intake on this?
Yeah, so before I say anything, I think I do completely agree with what Dr. Varikanchari has to say. Um, we should have, a pathway for early integration of interventional radiology in India as well, much like what has been adopted in the United States. I think we will see that in the coming years. And yeah, I mean, it's a dream to actually recruit students directly from medical school because I don't think I had any ounce of idea of what interventional radiology was during my medical school. But yeah, we could definitely kind of integrate exposure to interventional radiology early on during medical school as well. Having said that, at in my country at the moment, essentially the MD program that runs for radiology, which is immediately after internship, that spans around 3 years. So 3 years is essentially heavy on diagnostics. So we have a very strong grounding when it comes to exposure to CT, MRI, as well as ultrasound, and the didactic heavy lectures as well as reporting. Our exposure, like I said, is institution dependent, often observational, and it's rarely sufficient for any kind of independent procedural confidence. So, once we've passed through the diagnostic radiology residency, we have the option to opt for a 3-year DM course, which is a doctorate course, or we have the option, to perhaps pursue senior residency in diagnostic radiology for a couple more years, depending on what kind of exposure you've had and what you want to pursue in life, and probably apply for a fellowship. Or again, we do have, some of our, I know some of my residents and fellows currently at the moment are well late into their careers, primarily because they haven't been able to have the kind of exposure that I did during the early years of their residency. And once they've actually been able to establish a practice in centers that do offer exposure to IR, they realize that, okay, this is something I might want to pursue. And that's when they go ahead and appear for the exam. And it's completely up to the discretion of the candidate if or not they would want to pursue a DM or a fellowship. And that's when you have a 3-year versus or a 6 month to an 18-month course in interventional radiology. Again, this could span just the head to toe interventions, or you could delve into the more intricate neuro interventions as well. And I must warn you, the IR training is also dual practice, where you do spend part of your time, probably 6 months out of the 3 years, doing the diagnostic rounds, because I strongly believe you need to be an exceptional diagnostic radiologist to actually be a good interventional radiologist. So, and that's how you go about it. And even as I practice now, so when it comes to my practice, I do 50 and 50. So I have 50% of my practice is diagnostic neuroradiology and 50% of it is interventional neuroradiology. But I will say that, the diagnostic practice of mine has gotten me a lot of referrals. I've been able to pick up, unruptured aneurysms, AVMs, what say you, on the diagnostic scans. And I do get a lot of referrals. I essentially self-refer the patients to myself, once I'm able to pick on those in my diagnostic postings. Yeah.
That's awesome, Dr. Sabha. Thank you for giving us that insight. Dr. Tan, can you give us your insight?
Yeah, I think generating interest in interventional radiology among medical students has been a challenge, I think, globally. We are targeting a group of students who are, have exposure to many opportunities to be exposed to lots of specialties, and they may not even know what IR is to begin with. So I think at a very basic level, hospitals should have a tie-up with universities to have students special student selected components or even electives so that the students can come and spend a short degree of time to understand what interventional radiology is. And also with regards to national conferences or local conferences, that there's a student component within it so that students can engage with us and to find more about the specialty. We do have a student elective component in my hospital. Just to put an advertisement plug, we're very happy to have overseas students join us as well. In fact, this year we're receiving up to about 18 students already from overseas, and that's just the overseas cohort, and there's still many local ones who are coming as well. So very happy for any one of you who are interested to come and join us in Singapore General Hospital. One thing to say is that I think my UK counterparts are doing really well in the medical student sphere. They were very early adopters of creating programs to try and excite medical students to join us in IR. And these are student-for-student-led societies. There are many of them in the UK. And I think they've worked very well with the national societies as well as the international ones to try and create a lot more of an international program to try and attract students to join us. Yeah. Thank you.
Thank you so much, Dr. Tan. Dr. Park, would you like to?
Yes, so just like the other doctors from the other countries mentioned that the problem that we have is just like the diagnostic radiology, we sometimes can be invisible. So we try to be visible, and we are trying to come up with some student outreach program during the yearly society meeting. And now what my institution does is that we open up the subspecialty internship for third and fourth year medical student to join in the interventional radiology for about a month or two during their summer vacations to expose what we do. And the younger interventional radiologists open up their own outpatient clinic where they meet the patients on outpatient basis and to try to expose what we can do for the patients on the outpatient basis. And for residents in diagnostic radiology, we have a monthly session where we share interesting cases, and we try to give them opportunity to present the cases and show how the interventional radiologists discuss and approach the difficult cases.
Thank you so much. Yeah, right along with what Dr. Park said and with many others had mentioned, when the clinical training comes into play, how is that integrated into your training modules in your country? And do IR trainees have direct patient care responsibilities in your respective countries? Dr. Zurstrassen.
Well, it's a very good question because unfortunately, we are not the primary care provider. We usually need to be referred by a clinician or a surgeon to treat our patients. That's our reality in Brazil. It's very, very difficult to a patient to look directly for interventional radiology to treat a fibroid, to treat a prostate enlargement, or to treat a liver cancer. So, and it's an action that we are trying to do here in Brazil as a society, trying to show to the population in Brazil that what interventional radiologists can do with a lot of the diseases that you know for sure. And it's a work that should be done constantly to trying to change a little bit that situation, because as long as we need a clinician or a surgeon to refer a patient to us, we feel we remain without power, considering improve our patient care, improve our procedures, and growing as a specialty. I don't know what you've been doing in other countries, but I think it's an important question to be recognized as a primary patient care situation.
Thank you, Dr. Ahmed. Does it differ in your country?
I do think I fully agree with what Dr. Charles has to say. We should be known as, we could be the index physician's patient's contact, but it's a lot trickier when it comes to, say, neuro IR. But I will say that, we do have direct patient contact when it comes to neuro IR in our country. And that's precisely how the program is structured as well. So we do have the very procedural patient contact, which is nearly universal, and this is followed in all of the institutions across the country. So across most centers, the trainees are involved in, say, pre-procedure patient evaluation. We do look at the history, the imaging review consent. Many a times we do pick on, findings that may have been overlooked primarily because of how we are primed about the pathophysiology of the disease and also the presentation. Of course, we speak to the patients about, what is going to be performed, the inter-procedure care, and also the post-procedure monitoring. So this level of contact is absolutely unavoidable and routine, particularly in high-volume public hospitals, which is mostly the case with most centers in India. And then, of course, we have the longitudinal clinical care. This, I would say, is rather variable. So when I speak of continuity of care, it is essentially what defines clinical IR. This varies widely. So particularly in centers with IROPs, clinics, dedicated IR beds or daycare units, admission privileges, and also multidisciplinary participation, trainees gain experience in outpatient evaluation. We also have them, gain experience in decision making as well as patient selection, and of course, follow up and complication management. In contrast, where IR essentially functions as a procedure only service, trainees' contact is often episodic when it comes to the longitudinal care. It's centered around referrals rather than ongoing care. So, having said that, I will say that, I have you could establish a repertoire and have, clinicians refer the patients to you based on how well you report a particular scan. I will say that a lot of my cases also come off just good diagnostic reporting. I think that is something I've established in my years as an early, neuro IR in practice. So yeah, and I will say that, for my vascular interventional radiology colleagues, we do have OP setups in most of the institutions in my country. This could vary widely with respect to private practice. I think in private practice, it is largely referral based, but at an institutional level, we have tried to bridge that with running OPDs and having direct contact with the patient. It's very important that you have a face in terms of patient management, and the patient is also aware of what an IR is. And I think one of the primary ways to do that would be to actually communicate with the patient right from the very go. Yeah, thank you.
Dr. Tan, how is it in Singapore?
Yep. So, yeah, I think clinical IR cannot be understated. I think it's really something that's cannot be something that's new now. It definitely has to be part of your practice. We do not have direct admission rights, so any patient that we see and needs a procedure done would eventually be admitted under the referring specialty. So just to give an example, if a patient was coming for radioembolization, Y90, then depending on which specialty they are referred by, for example, oncology or hepatobiliary surgery or gastroenterology, they will go under the primary referring physician. Most of our referrals are via specialties rather than direct referrals, whether it's from the primary general practitioner or for self-referral. Those form a very, very small part of the patients that we see. Even so, if they do self-refer, we would always get another specialty involved, because ultimately when the patient is in the hospital, they are under the purview of the subspecialty of that disease condition. So besides that, our other clinical involvement would be seeing the patients before and after the procedures in the hospital. We have quite a large pool of medical officers, residents, as well as fellows who form part of the ward round team, where they would review patients, for for any procedures that need done and consent, and also review the patients after the procedures. In fact, recently we've initiated a rounding session. So there's a dedicated consultant or attending who would see all the patients in IR who have had procedures that day on behalf of the department, just making sure that there's a second layer of accountability on top of the primary care team to make sure that these patients have had their procedures done properly without any complications. Thanks.
And finally, Dr. Park.
And similar to the other countries, most of the procedures that we do are referral basis. However, the two of my colleagues, they have their own outpatient clinic. One professor is working on the myoma embolization and endometrial therapy, and the other colleague is focusing his work on the embolization of the permanent AVM and visceral aneurysm. And for those patients, we admit the patients and the resident and fellow working on that specific month gets to do the rounding and seeing the patients and care the patient from the admission to the discharge. And just like extending from what I said before, and the younger interventional radiologists are trying to open up their own clinic within the University Hospital and outpatient basis to do more clinical interventional radiology work. And on top of that, and for the most of the elective procedures, whether it's radioembolizations or other simpler cases, we try to have the patient sent from the referring doctors and meet the patients as the clinic before we do the procedures. So we are trying to expand our reach into the outpatient clinic and the seeing the patient before the procedures.
That's awesome, Dr. Park. Thank you for that insight. And I would like to ask the panelists, how does the healthcare system in your country, how did that impact your IR training and its practice? Dr.
Should I start?
Charles.
All right.
Yeah,
Okay.
you can. You
Here?
can just chime in.
Here in Brazil, it's a very large country and a very heterogeneous population. So we have the public system who takes care of about 70% of the population, and the private system. So the public system, there are some limitations. We can't perform, for example, one of Y90 procedures in the public system. We don't have enough money to do that. So instead of doing to treat the liver cancer with Y90, we may treat with TACE, which is good as well. So another issue. We don't have ablation in the public system as well. Some of hospitals, the most important hospitals in some states, we can do ablation, but most of the time we should do ethanol injection instead of ablation. So it depends where you are working. So in the other side, here in São Paulo, there we have the private system. We do almost everything what is being doing in the US. We do heart embolization, we do thrombectomy with with very good devices. We do we treat AAA thoracoabdominal aneurysms. So it depends. Yeah, it depends a lot where you're working. If you work in Amazon, for example, you don't have enough resources to do high tech procedures as we may do as in interventional radiology. But in the other hand, if you are in São Paulo or Rio or some other places in Brazil, in Rio Grande do Sul and other states in Nordeste, you might do high-tech procedures as all of you have been doing.
Awesome. Thank you, Dr. Charles. Dr. Ahmed?
Yeah, I think with India, it's quite different. So essentially, the IR case mix in India is just fabulous. So, and of course, the endemicity of a certain condition is varies, according to the geography. So much like that, we have an increased prevalence of, say, aortic diseases, TB-related vascular pathologies, and say, hepatic venous outflow obstructions. A lot of these are a lot higher in incidence as compared to the other countries. So essentially, there's a dramatic rise in procedural volume as well over the last 2 years, as we've been able to diagnose these conditions a lot earlier as compared to what was done about a decade or so earlier. Having said that, there is still a large gap when it comes to in terms of infrastructure. So we have about 40,000 hospitals nationally, just a ballpark number, but less than 1% of these have dedicated IR facilities or faculty. And much like what Dr. Charles said, it varies widely as to what could be offered to you in terms of the management of a particular condition, depending on whether you are approaching a hospital in tier one cities as opposed to, say, tier two or tier three cities. Having said that, I did spend, a couple of months in the UK, and I know the system in the United States as well is largely insurance based. But of course, it's rather different in India, where insurance is picking up, and of course, there's a lot of out-of-pocket pay as well, and you could have private insurance companies chiming into. So this also has a bearing as to what you could be able to afford in terms of what these large private centers could offer. When it comes to the government center, now I work in a public healthcare sector. It's a purely central government funded institution. So in our institution, we have certain government funded policies which allow us to perform these procedures at basically zero cost. But this is not available in all of the centers in India. And this also varies largely among the states as well. So, some of these are funded by the central government, some of these are funded by the state government. There's a lot of geopolitical involvement as well, but this has a direct bearing on what the patient could afford and what you could offer to the patient in terms of management. In terms of the complexity of cases, I think we rank really high in terms of what we see as IRs, vascular IRs, neuro IRs, in terms of what we are able to perform for them. I will say that we are not the fanciest when it comes to being able to perform, offer these kind of services, but we are quite up there. I think at most of the lectures that I attended today, we do offer most of of those services, but this may not be the case in tier two and tier three cities. So it does vary widely depending on the geography of the place as well. So I think as a doctor working in an LMIC country, when I treat a patient or when I'm even speaking to the patient, I have to factor in all of these, nuances when I explain to them that this is what I'll be able to perform, and probably this is what you will be able to afford, and so let's go about it. Particularly in cases where there's the out-of-pocket expenditures, it becomes very important for us that we're still able to provide the best of the best services to the patient, but also taking into consideration that we shouldn't amp the bill as high. This is in vast, I think, contradiction to what I've seen in the UK, where it's entirely funded by the NHS. I'm not quite sure how it, works in Singapore and Korea. We will hear about it, but this is precisely how it works in my country. And yeah, a lot of things I need to worry about before I actually decide on, this is what I'm going to be doing for the patient. Thanks.
Awesome, Dr. Sabha. Dr. Tan, would you like to chime in?
It's really interesting to hear what my earlier two speakers have said in terms of geography as well as in costing. Singapore is not a very big country by size, so probably about 45 minutes from one end to the other if you drive in a straight line. And we have a population of nearly about 6 million, and Density-wise, I was just Googling it, it's about 200 times that of the United States and 2,000 times that of the Australia. So quite interesting is that even though we're quite a small country, there is still this central and peripheral divide in terms of healthcare needs and concentration on specialization or specialties. So a lot of the more complex procedures are generally being done in the bigger teaching hospitals in the central belt. But that's also a concern because some of these specialty needs are also needed in some of the more peripheral hospitals. And I guess if you were a larger country, that could be a big problem because logistically, how do you transport a patient safely over long distance to get that specialty treatment? But in Singapore here, you could potentially, have all those treatment concentrated in one site and actually have it all done. An example of that would be something like EVAR for aortic aneurysm disease, or even radioembolization where you need nuclear medicine facilities to be able to do the service. So in that regard, Y90 is only being done in two main hospitals at the moment, I would say, mainly because of the nuclear medicine facilities that are needed for it. But if you look at something that's a bit more common and complex and that's needed is dialysis access interventions. Diabetic disease and dialysis access needs is a huge thing in Singapore. And in spite of that, the training needed to get people up to speed, not just in the IR, but also our vascular as well as our interventional nephrology colleagues, is still playing catch up to it. We are unable to provide some of these essential services in the peripheral hospitals. But hopefully in the next 5 years, we should be able to get the manpower up to speed and be able to provide some of those services at a very high level in the district hospitals. On the subject of costing, most of the if you're a Singaporean citizen, you're very well covered through your pension, government subsidies, as well as own individual private insurance schemes. So there's really not so much of a concern when it comes to procedural costs and as well as the type of devices that we use, because the government has actually initiated programs to make sure that there's not too much of discrepancy in terms of the pricing of products, such that one company cannot charge so much more than the other for any particular balloon or closure device. And I think that really helps to keep the cost at a level that's manageable in terms of subsidies as well as the money that the patient needs to come out of pocket to deal with their conditions. Yeah. Thank you.
Okay. So the situation in Korea, I think, is somewhere between Brazil, India, and Singapore. We are a relatively small country, and most of the big university hospital is located in Seoul. So easy accessibility for the patients to visit this big center makes the medical service widely available for those live in the rural area, because most in Korea, most of the people can get to Seoul within like 4 to 5 hours. And so in terms of the medical expenditure, most of the medical expenditure is covered by the healthcare system. And so the procedures that are deemed important and prevalent among Korean population, they are usually covered by the government. And so before the government coverage, the radio embolization used to be about $15,000 per patient, but now about half of that is covered by the government. So the patient only needs to pay a little less than 10,000 US dollars. So it's the popularity of the radio embolization is gaining recently. And on top of that, the people with the end stage renal disease, they need to only pay 5% of the whole procedure, so they do not need to pay as much. And so those patients undergo the PTA like every 3 months to keep the access readily available for the hemodialysis. But the downside of that is some of the procedures are not covered by the government. The patient have to pay out of their own pocket or from the private health insurance. And for those procedures that are covered by the private health company, they are sometimes done regardless whether it's really necessary or mandatory for the patients. And those procedures include like varicocele embolizations and I think that's pretty much it. And the downside of that is that some of the newer devices are not readily introduced. So when I went to some of the international meeting, I see fancy techniques such as like thrombectomy devices, permanent embolizations, and hydrogel coil and microvascular plug. They are not introduced in Korea because the healthcare system has to think about the expenditure and justice for the dividend of the medical expenditure. So, and actually, there's a viable stand that was being withheld from the country because the government is not paying enough money for the company to provide the device. So, yeah, so I guess there's a upside and downside to the procedures that we can do. And on top of that, and so all the procedures that we have to has to be exactly have to be approved by the Korean health system. So nowadays the transcatheter muscular embolization is not really approved in Korea. So on most of the cases that we do is on the experimental basis. So we have to be approved by the institutional review board to do the procedure of these procedures on the patients.
All right, and so my next question, and it might be our final question depending on how much time the responses take, is how do you see or how do you believe collaboration between countries internationally will grow your practice or improve VIR training in your country? What do you want to see out of international collaborations, essentially?
Well, I think it's a great challenge, but also very important if we could collaborate among countries, among South America, United States, Asia, Europe. But we have to find a way to connect and then to discuss the problems that you have, the problems that I have, the diseases, and then some maybe one idea that you have there may help a patient here in South America, something not just about patient care, but also in education would be awesome if we could do that. Unfortunately, there are a few places that we might connect. For example, the meetings. I believe the most attended meeting in the world is the CIRSE that is in Europe in September, or sometimes and other meetings in the US, for example, the SIR meeting. But I like very much this very meeting that it's online. I think it would be it's a great value that because it can connect people all around the world in a very easy way, and then we might discuss our challenges and trying to solve problems that all of us facing in the daily basis. Well, that's it. Thanks.
Thank you. Dr. Ahmed, how do you want to see international connections
Yeah,
grow?
I think my answer boils down to one of the earlier lectures we had at the meeting here. So I think Dr. Kaja, if I'm not pronouncing his name wrong, so he showed us beautiful cases of fenestrations and, stenting in cases of dissection. And, it was one of the few cases that actually provided me with the impetus to pursue IR early on in my training. And we had this wonderful, wonderful interventional radiologist at our center who had learned of this, mastered this technique through his training in the United States and was able to provide that to the society and the population of India. So I think at the very core, like I said, India is a very populous country. We have about 1.5 billion people, and the caseload is enormous. So is the complexity. So when it comes to international collaborations, we could learn from each other. We could start off with, sending our trainees for probably a month or two of observerships to countries outside. I myself pursued, one of these in the United Kingdom. We are not big on intrasaccular devices in India, primarily because of the cost, but I was able to learn a lot of, nuances as to how these are deployed, and which of my complex cases would be a good one for the deployment of intrasaccular devices. So yes, we could start off with, having international collaborations as competency benchmarks where decision making milestones, complication management framework could be established as well. Having said that, I will also say that research and academic visibility is of great importance to us, particularly now that we have a multitude of registries, and so we could have joint multi-center registries on stroke, on embolization, management of hepatocellular carcinomas. What say you? We could also have a shared protocol design and also statistical support. I think with me, what I'm really inching towards is establishing a registry for some of the rarer conditions. I mean, the so-called rarer conditions, but us being in the Asian subcontinent, we see a lot more of that as opposed to what is seen and what is picked out in, say, the United States or the United Kingdom. So if we could establish a registry and see how that goes about, that would also be something I would be very interested in. And I do also believe that co-authorship and leadership roles, particularly in defining guidelines, and to have people from LMIC countries to gain perspective from LMICs would also, we would do a lot better if we had an LMIC perspective, among the guidelines, among the authors that devise these guidelines. To have someone with an LMIC perspective would essentially make it something that could be broadly, adopted in most of the countries of the world, as opposed to being able to adopted in a certain sector of the world. So yeah, we could do a lot with international collaborations. Thank you.
Yep, I
Thank you.
totally agree with Dr. Sabha, whatever she's mentioned in terms of research, collaboration, and everything. Not much further to add to that. I think hopefully with the improvements in our clinical standards, our research output, as well as educational outreach, we will eventually be able to achieve something at a global level. And I think the hope is that we will eventually be able to be recognized as a full-fledged specialty in many, many countries around the world. Yeah, thank you.
Yes. To add on top of that, so I think this I mean CERC, SIR, they are all great, but I think they are at the level formal level. But this Zoom meeting, I think it comes to more personal level. So sometimes you might think, oh, this is so trivial. Can I ask these questions in the CERC or SIR? But when you meet the lecturer or the other doctors from the other country, I think it's easier to talk to them, questions, and get the feedback right away. So I think these international meetings, conferences where we specifically focus on certain procedures or certain disease is interesting, and share some thoughts and brainstorming on the idea on how to approach the patients. And finally, I posted a website on the chat link. And so every February, we have a course in Korea, which is called International Intensive Course for the Interventional Radiologists. And I understand there are a few doctors from the Brazil, Singapore, India, and the States who have come to this meeting. So during this week course, we provide all the broad spectrum of the IR, and actually the participants can do the hands-on practice on the pig, where they can deploy coil, glue embolization, deploy stent, and practice the IVH filter insertion and removal and tips. And so I'm working as a moderator for these animal hands-on sessions. So if you are interested, I think that's good way for you to do some of the hands-on as well as getting some insight into all the different procedures of the IR. And so if you have any questions, you can feel free to contact me, and then I can assist you further.
Okay, I think that's all we have time for the international panel. I want to thank all the panelists again.